My name is Samantha Wetzel, and this is my DMP project presentation, The Effects of Postprandial Music on Anxiety in Patients with Eating Disorders. According to the APA, eating disorders affect roughly 5% of the population in the U.S. Two main eating disorders include anorexia nervosa and bulimia nervosa. Anorexia nervosa is characterized by low weight, intense fear regarding weight gain, and preoccupation with weight and shape, and can be further characterized into restricting and binge purge subtypes. Alternatively, bulimia nervosa is identified as a disease involving recurrent binging episodes with a loss of control, followed by compensatory behaviors such as laxative abuse, vomiting, and overexercising. Anxiety is a significant symptom of treatment for EDs, oftentimes influencing an individual's ED behaviors and disease severity. Many times, a patient with an ED has comorbid anxiety, depression, or both, with anxiety often occurring before the diagnosis of the ED and persisting well after the ED has been treated. Anxiety is a significant factor in both the development and continuation of ED behaviors, and dysregulation of emotions, and it should be recognized and addressed for successful treatment. The authors of this study also found that anxiety could be a causal factor of restrained eating, emotional eating, and external eating in children. Lloyd et al. Suggested that children with anxiety disorders at the age of 10 are more likely to develop anorexia nervosa before young adulthood, and that worry as a child can transition to an anxiety disorder later in life. In another study by DeBoer and Smits, anxiety was identified as a risk factor for ED in life, with 65% of participants with EDs having a comorbid anxiety disorder, often diagnosed prior to the ED. 8.9% of participants with an ED, or 37.3% of participants with disordered eating behaviors, had a confirmed diagnosis of a comorbid anxiety disorder without a concurrent depressive episode in a Garcia et al. 2020 study. While a common symptom and experience of individuals with EDs, anxiety also poses a significant barrier in treatment. It has been studied and found that negative emotional symptoms, life stressors, and eating behaviors are all related, with anxiety, depression, and stress linked to unhealthy eating. High anxiety has also been linked to higher EAT26 scores, with anxiety contributing to worsening of and maintenance of ED behaviors to regulate the negative emotions experienced regarding shape, weight, and food. One hypothesis by Lloyd et al. Theorized that anxiety fuels the restricting behaviors of anorexia nervosa. They suggested the ED behaviors are a coping mechanism to quiet the anxiety, thus encouraging the continuation of restricting in this population. No single method has been proven effective for ED treatment, and treatment should be tailored to the individual patient. One intervention that has shown promising results for those with EDs is the implementation of music therapy. Bibb et al. Found that music therapy during the postprandial period, which is the period immediately following a meal, decreased feelings of anxiety compared to the standard postprandial procedures. All participants of the study described music therapy as a distraction from the meal they consumed immediately prior. A second study from Bibb et al. Used music therapy in patients undergoing outpatient eating disorder treatment and found similar results. The study discovered there was a reduction in anxiety despite how long the patient had been undergoing treatment. In one study, participants with EDs described their interactions with music as mostly positive, 58% stating they use it to cope, 78% reporting it distracts them from their thoughts, and 76% saying they use it as a distraction from their feelings. The participants in this study also reported additional benefits of music therapy, such as forming connection to their peers, expressing negative emotions in a healthy way, and helping with loneliness. A benefit that music therapy has over other therapies is that it's easy for a participant to feel validated without putting forth a lot of effort, allowing them to reconnect with themselves and others on behalf of the therapist. Music therapy can also easily be implemented in a group fashion with little adaptation, allowing for utilization during social times of treatment, such as after meal times. This is significant because mealtimes prove especially distressing to both patients and staff. and the ability to utilize healthy coping mechanisms is a key factor of ED treatment. The proposed project was a QI project implemented on an inpatient ED unit in the Midwest United States. The purpose of the proposed QI project was to improve the implementation of music therapy on an ED inpatient unit as a means of reducing anxiety. The primary aim of the project was to observe a reduction in anxiety among the patients during the weeks that music therapy was implemented compared to when it wasn't. The PICO question is as follows. Does the implementation of music therapy after meals and snacks decrease anxiety among ED inpatients compared to standard postprandial procedures? The DMP scholarly project was conducted at an inpatient eating disorder unit located in the Midwest. The sample included information gathered from the electronic medical records, or EMRs, of patients with EDs. The focus of the study was ED patients with anorexia or bulimia that are undergoing treatment for their ED. Emotional dysregulation, such as anxiety, is both a risk factor for EDs and ED behaviors, while also perpetuating the ED behaviors. Music therapy has shown promising results in lowering anxiety in the ED population. A sequential inclusion and exclusion process continued until present date was reached at the time of the review. Prior to the QI project, there was no consistent protocol for the observation time following meals and snacks on the unit. To consistently implement an evidence-based practice on the unit, a QI project was implemented in collaboration with nursing staff on the unit. The following strategies were implemented for the project. Approval was obtained from unit manager and directors prior to the project starting. The staff on the unit was educated on the purpose of the project and how to implement the intervention after meals and snacks. Additionally, the staff was informed of the start date to prepare for implementation and ask the author any relevant questions. Instrumental music that was non-lyrical in nature was played on a CD player located in the day area after meals and snacks during the patient's observation time. A 2-week trial period was set to work out adjustments prior to the official planned data collection date. Staff tracked whether the music was implemented and whether patients attended. The goal was to implement the music 100% of the observation periods when the patients weren't in other groups. Applications for IRB approval were sent to both Maryville and the facility. Data collection began after IRB approval was obtained with a retrospective review of the EMRs. Effectiveness was mainly measured using the patient's GAD-7 scores during their treatment. The pilot project was used to determine the effectiveness of the QI program designed to decrease anxiety experienced by those with anorexia and bulimia on the inpatient ED unit, promoting better health outcomes and patient satisfaction in this population. A quantitative exploratory design through a retrospective chart review was utilized for the project. Participants were not engaged and the minimal amount of PHI was abstracted from the EMRs. The retrospective EMR review used a convenient sample of patients admitted on the unit during the pre- and post-intervention periods. A goal of 106 patients was included in the study. The beginning of the data collection period for the post-intervention group was February 28, 2022. The goal was to include 58 EMRs in the pre-intervention group and 58 EMRs in the post-intervention group. Inclusion criteria for the EMR that were included in the data collection are the following. Ages of between 12 and 89. EMR has documentation that the patient was admitted during one of the pre- or post-intervention periods. EMR has documentation of a discharge diagnosis of anorexia or bulimia. The EMR has documentation of GAD-7 scores. EMRs were excluded in a specific order. The exclusion of the EMR were carefully examined in the following order. If the EMR indicated that the patient was not admitted during one of the two periods, it was closed and no data was collected. If there was an absence of a discharge diagnosis of anorexia or bulimia, the chart was closed. If the patient was unable to complete 3 or more independent GAD-7 assessments during admission, whether due to cognitive impairment, admissions less than 2 weeks, etc., the chart was closed. If the patient had an admission GAD-7 score of less than 5, the chart was closed. And finally, if the patient was documented as attending less than 50% of the offered observation periods, the chart was closed. A sequential inclusion and exclusion process continued until the EMRs of currently admitted patients were reviewed. A Mann-Whitney U test takes the ordinal data using the Statistical Package for Social Sciences SPSS program. The data was considered significant if it was within an alpha measurement of 0.05. A step-by-step outline of the project's protocol is as follows. QI project intervention of playing music after meals and snacks was implemented. There was no data collection at this time. Participants were not engaged, and the minimal amount of PHI was abstracted for the purpose of the project. It was a retrospective chart review. IRB approval was obtained from Maryville in the facility, and the data collection process began. The Enterprise Data Analytics Department, or EDA, supplied the author with a list of specified data on who participated in the QI project starting 2 weeks after the implementation of the intervention. Additionally, the EDA provided the author with a list of patients from 1 year prior to the implementation of the intervention. The author collected data on the same number of patients from a year prior as there was included in the intervention group. This list was stored in a locked area where only the author had access and on a computer that was password protected with a password known only to the author. Upon completion, the list was destroyed as appropriate. The author reviewed each EMR prior to determine if the inclusion criteria had been met. This process was applied to both groups to determine inclusion in the study. For the intervention group, the data collection period began 2 weeks following implementation of the intervention, with the expectation that there was consistent implementation on the unit by that time. Each EMR was given a numerical number on a data collection sheet without identifying PHI. The minimum necessary PHI was collected and transcribed to the data collection sheet. The data collection process stopped when the list reached present day at the time of the review. This author then went back 1 year to obtain the same number of EMRs for the study as was collected in the intervention group. Once the data collection stopped, the list of EMRs was destroyed as appropriate. The main data collection instrument was the GAD-7. It is a generalized anxiety screening tool that was developed by Spitzer et al. In 2006. Instrument collects self-reported data on different anxiety symptoms, how often these symptoms occur, and how impactful the symptoms are on the individual's functioning in their daily life. It classifies the level of anxiety in the recorder as being minimal, mild, moderate, and severe. The instrument was used to determine whether the intervention could reduce the GAD-7 scores in the participants, thus inferring that their anxiety also decreased. The instrument has a sensitivity of 89% and a specificity of 82%. The patients fill out a GAD-7 weekly as part of their regular programming. Additional information gathered from the EMRs was de-identified and imported into the data collection sheet. The group the participant was in, patient sex, discharge diagnosis, and comorbid psychiatric disorders, were given numerical codes for data analysis of nominal data. The collection sheet was assigned the EMR a chart number and recorded all this extra data. The data collection sheet could record up to 58 patients in each group with a goal of 106 patients. In addition to the data collection sheet, a tracking sheet was created to keep track of the intervention. Intervention was implemented and who refused or wasn't there during the time of observation. Here you can see the GAD-7. Here's the data collection sheet. And here's the track sheet created for the project. Descriptive statistics were used to assess the demographic data and data relating to participants' diagnoses in the pre- and post-intervention groups. Of the 35 participants across the two groups, 89% were female and 11% were males. Among both groups, 71% had a discharge diagnosis of anorexia restricting type, 17% had a discharge diagnosis of anorexia binge purge type, 9% had a discharge diagnosis of anorexia of a different subtype, and 3% had a discharge diagnosis of bulimia. When comparing comorbid psychiatric disorders, 9% had comorbid anxiety alone, 6% had comorbid depressive or mood disorders alone, and 86% had both anxiety and depressive or mood disorders. None of the participants had an absence of a comorbid psychiatric disorder, and none of the participants had a psychiatric disorder that wasn't an anxiety or depressive disorder. The unit has the capability of taking patients as young as 12 years old. Of all the participants, 31% were between the ages of 12 and 25, 20% were between 26 and 35, 37% were between 36 and 45, 9% were between 46 and 55, and 3% were over the age of 65. None of the participants were between the ages of 56 and 65. The Mann-Whitney U-test was performed using SPSS to examine the mean ranks and significance value of the difference in GAD-7 scores on the unit. The Mann-Whitney U-test suggested that there was no statistically significant decrease in the GAD-7 scores of the post-intervention group when compared to the control group, with a p-value of 0.987. In fact, the test showed that the post-intervention group had a lower difference of GAD-7 scores compared to the control group, meaning that there was less of a decrease between admission and discharge scores for the intervention group versus the control group. Prior to the project, there was a lack of consistent intervention following meals and snacks on the unit. Sometimes on the unit, the patients may have a group, other times therapy, or they would have another programming activity that took them away from the observation period. The project helped to establish a consistent intervention during the postprandial period after the patients ate and when they were not in one of these prior obligations. The intervention was successfully implemented on the unit, and consistency of the implementation improved as the project progressed. Based on the SPSS analysis, the results of the project showed there was no significant difference between the scores of the pre- and post-intervention groups. It is possible that the sample size performed with improvements, such as a larger sample size, may prove to have statistical significance. This project had evidence at times that there was missing data from the analysis. The researcher relied on the data from the track sheet on the unit and chart data supplied from the Enterprise Data Analytics Department to perform the data analysis and choose participants for the study. The completed track sheets upon review showed that there were meals and snacks during some of the days that had nothing recorded. This could mean that the music was not turned on after those meals and snacks, or it could mean that it was turned on and wasn't recorded. To account for this, this researcher adjusted the analysis to focus on the data that was presented. The analysis went from reviewing data from every meal and snack every day to reviewing the meals and snacks that this author had access to. In addition to missing data for some of the meals and snacks, some of the data from the EDA showed some discrepancies. Included in that data were the admission and discharge dates for each of the patients. While in treatment, the patients are meant to fill out a GAD-7 each week during one of their scheduled groups. There were instances where the number of GAD-7 scores were lower than the number of weeks the patient was in treatment for. This may be due to a multitude of reasons. The patient may have been with their doctor or another member of the healthcare team during the group where the GAD-7 was administered, or the patient may have been ill and couldn't attend the group with the rest of their peers. To account for this author used the first recorded GAD-7 score as the admission score and the last recorded GAD-7 score as the discharge score. The project found that there was no statistical significance between the measurements of the GAD-7 screening scores of the control versus the intervention group. The significance level was 0.987, calculated with the Mann-Whitney U-test for a two-tailed study, and the significance level was 0.05. Surprisingly, the study found that the control group had a larger difference in their GAD-7 scores with a mean rank of 18.06 than the intervention group, mean rank of 17.94. These results were calculated with a total sample size of 35, with both a pre-intervention control group and post-intervention group. These results are surprising considering the other studies found during the literature review. Bibb et al. Conducted a study that found music therapy could be used as an alternative coping mechanism for inpatients with anorexia following mealtimes. The study found that music therapy could help relieve the anxiety and distract patients from the meal they just consumed. Likewise, a subsequent study found similar results in partial hospitalization program for EDs. The participants of that study had lower levels of perceived distress as noted by the subjective units of distress scale. It's important to note, however, that there were differences in the way these projects were conducted versus the studies from the literature review. Most notably, the BIB studies had the advantage of having a licensed musical therapist performing the postprandial sessions. One of the project's strengths is that it was implemented on a small 8-bed unit in a hospital. Because of this, it was easy to communicate the expectations and provide education regarding the project to the unit staff. Additionally, this made it especially easy to have an ongoing discussion regarding the ways the project could improve, changes to the intervention, and details regarding the project's aims and purpose. This also allowed the author to easily monitor whether the intervention was being implemented during the project's duration. One large limitation was the lack of consistent implementation. Due to the unit's programming schedule, the music was not played consistently during observation time, as the patients often had group to attend to immediately following a meal or snack. The next main limitation of the study was the effect of the patient response. Many of the patients were unhappy with the intervention and thus would try to get staff to skip playing the music after meals and snacks. This, coupled with staff frustration at their response, could have led to decreased implementation. The study had a small sample size. The sample size needed to achieve a power of 0.8 was 106 participants. Not only did the project fail to meet this power, but the smaller sample size also meant that the data was heavily influenced by each participant's change in score rather than mildly influenced. Additionally, the sample of participants consisted of a convenience sample of patients admitted to the unit during the time of implementation and 1 year prior. This prevents this author or readers to generalize based on the data in subsequent analysis. The final main limitation of the study was the lack of a licensed musical therapist and the constraints that the current schedule placed on the availability to conduct the study. In the studies conducted by Bibb et al. In both 2016 and 2019, the participants of the study had a structured, guided music therapy session that was led by a registered music therapist. Due to the current programming on the unit and inability to secure a music therapist for sessions, the project needed to be adjusted to fit the schedule of the unit. Implications for practice. Because of the results of the project and the limitations and restrictions, this author does not recommend any changes to practice based on the results. The data revealed that the project did not produce a significant change in the patient's GAD-7 scores from admission to discharge. The project was not able to reject the null hypothesis that musical intervention has no significant effect on GAD-7 scores. This differs from similar studies found during the author's initial literature review. Implications of research. Despite its lack of effect on current practice, it could be useful in future research should the study ever be repeated. During the study, the patients voiced they were unhappy with the music intervention that was in place during the life of the project. If the study were repeated, some changes to the intervention would be warranted. It's possible the patient's own preferences could have affected their scores, which may be considered soothing to the author, may not present that way to the participants. Allowing patients to choose the music played might affect the data and GAD-7 scores of the participants. Finally, the implications of policy. The project has a limited impact on policy on the unit. The results were not significant and the participants voiced dissatisfaction with the intervention. However, while it did not have a strong enough effect to guide policy, it did reveal that the unit procedure may need to be reviewed. Patients on the unit are largely expected to find their own activities to do during the postprandial period. This can pose a problem as the postprandial period can be especially distressing to those with EDs. This author recommends some consistent intervention be implemented, even if the intervention does not involve music therapy. Studies from the literature search show that music interventions can and oftentimes has a positive effect on the population. It is evidence-based intervention that has a benefit on mood, affect, and connections to others within those with anorexia nervosa and, in some cases, bulimia nervosa. Because of this, it would still be appropriate to implement a form of musical intervention for those with EDs. This may be better suited implemented as a structured group during normal programming hours. Changes need to be made to accurately collect the necessary data needed for statistical analysis after the conclusion of a similar project. Currently, this project does not have sufficient evidence to make one recommendation or another for current practice. Thank you for listening, and here are my references.